Welcome back to MLT 130. In today's lecture, we're going to be covering the outline on tumor markers. So this first part of the outline is going to cover the tumor marker definition and utilization. So what is a tumor marker? Any molecule can function as a tumor marker providing that it changes in circulating levels of the molecule to correlate with tumor presence, growth, or activity. It can be a product of malignant tissue or a substance produced by the body in response to malignancy. So are tumor markers alone diagnostic of cancer? No, not typically, as most markers can be elevated in more than one type of cancer. With the exception of PSA, that's a prostate-specific antigen. So how are tumor markers useful? They're useful in detection, tumor staging, monitoring therapeutic responses, predicting patient outcomes or prognosis, and detecting cancer recurrence. So what are ideal characteristics of an ideal tumor marker? These are very similar to the characteristics in the supplemental video that's also posted in Moodle. Number one, you want something that is measured easily in either blood or body fluids. You want a high analytical sensitivity of the assay method. It means the method can detect very small amounts, no false negatives. You want a high analytical specificity of the assay method. It means that the method only detects the actual substance, no false positives. You want it to be cost effective. And lastly, the test results can contribute to the patient's care and outcome. So this next section talks about the different types of tumor markers. So what are the substances in the body that we can use for tumor markers? And there's several different things. We can use enzymes, we can use hormones, we can use oncofecal antigens, and these are proteins that originate within the tumor cells that enter the bloodstream by secretion or breakdown product of the tumor. We can use carbohydrates. We can use proteins, we can use receptors and other markers, we can use genetic markers, and we can use tumor suppressor genes. This next section is going to go over specific tumor markers that you need to know. The first one is alkaline phosphatase. This is an enzyme, we know because the tase on the end of phosphatase. It's elevated in bone metastasis, and when you see metastasis, think about spreading or the cancer has already spread. Next is beta HCG, also called the human chorionic gonadotropin. It's used in the diagnosis of pregnancy, but it's also increased in trophoblastic tumors, choriocarcinoma, testicular tumors, and ovarian tumors. Trophoblastic tumors is usually referring to abnormal cell growth inside the uterus tissue that forms after conception, joining the egg and sperm, and this is a rare condition. And choriocarcinoma is referring to a cancer of the uterus. So we're looking at the beta HCG. It's ordered as a quantitative beta HCG when we're using it as a tumor marker, not as a qualitative positive or negative pregnancy test. So could a pregnancy test quantitative beta HCG be ordered on a male patient? Yes, this could help diagnose testicular cancer. The next is calcitonin. This is increased in medullary carcinoma of the thyroid. Medullary is just referring to relating to the inner region of an organ or a tissue. This is useful in monitoring treatment and reoccurrence of the disease. Alpha-fetoprotein, or AFP, non-maternal, is up next. This is an oncofetal antigen, which is a protein. It's useful in the diagnosis of liver carcinoma. And of course, it's ordered in non-maternal adults as a tumor marker for liver carcinoma. PSA is next, or prostatic specific antigen. It is prostate tissue specific, not tumor specific. A small amount is present in serum of males normally. It's used to screen for early prostate cancer in men. and it will be increased in adenocarcinoma of the prostate. Adenocarcinoma is referring to a malignant tumor in the granular structure. PSA will also be increased in men with a benign condition called BPH, benign prostatic hypertrophy, which is meaning increased growth, or enlarged prostate, which occurs in men with age usually. Physicians will usually order a total PSA as a screening test, but they may also order both a total PSA and a free PSA. Men with prostate cancer, not BPH, tend to have lower percentage of free PSH than men with benign disease. The next tumor marker is CA15-3. This is a mucin carbohydrate antigen, which is a glycoprotein. It's useful in monitoring therapeutic response for detecting reoccurrence of breast cancer in patients previously diagnosed with breast cancer. The next tumor marker is HER2/neu. It stands for human epidermal growth factor receptor 2. It is an oncogene. This is a gene in certain circumstances can transform a cell into a tumor cell. HER2/neu is used as a prognostic and preventative marker in patients with breast cancer. HER2/neu is increased in serum before adjuvant therapy associated with tumor size, tumor grade, and positive lymph nodes. In patients undergoing therapy, can serve as a marker for disease-free survival and overall survival. The next two tumor markers are BRCA1 and 2. Sometimes you'll hear it referred to as BRCA1 and 2 for short. These are gene mutations. It's used in patients who have a family history of breast and ovarian cancer to help determine predisposition to develop breast and ovarian cancers. Women that carry the BRCA1 have a lifetime risk of breast cancer, about 56 to 87%, in addition to a risk of developing ovarian cancer. Women that carry the BRCA2 have a smaller risk. Men with the BRCA1 and BRCA2 have a risk of developing the male breast cancer and other cancers. The next marker is CA549. This is an acid glycoprotein, and it's useful in detecting the reoccurrence of breast cancer. CA125 is up next. It is a mucin glycoprotein antigen, and it can be used as a marker for ovarian and endometrial cancer. Endometrial is referring to the lining of the uterus, and it's useful in monitoring the progress of patients. Next is CEA, which is the carcinoembryonic antigen. It is an oncofecal glycoprotein antigen. Serum levels are elevated in a variety of cancers, with colorectal cancer being about 70%. Other cancers that can see an increase include lung, gastric, breast, pancreatic, ovarian, and uterine cancer. Is useful in monitoring therapeutic response and detection of reoccurrence of colorectal cancer. The last three tumor markers that we're going to go over all are pancreatic markers. The first one is CA19-9. It's a glycolipid blood group antigen related marker. It is a derivative of the Lewis blood group system. It can be used as a marker for pancreatic, colorectal, lung, and gastric carcinomas, but clinically most useful use of CA19-9 is to monitor patients with pancreatic and colorectal cancers. Next is CA50. It's a blood group related Lewis. Its usefulness is that it is increased in levels in patients with pancreatic cancer. And the last tumor marker is another blood group related Lewis, CA242, and it can also be used to help diagnose pancreatic cancer. This concludes our lecture on tumor markers. If you have any questions or need any further clarification, don't hesitate to reach out, and I will see you in lab.